A warm welcome to my session today. Today's session on breast lump, we shall look at some OSCE slides on this important topic of breast lump. OSCE stations on breast lump. There are two types of such stations in the examination of a breast lump: interactive and non-interactive. The interactive OSCE stations, you'll be asked to take a history from a patient with breast lump. This is usually a standardized patient who has been trained to give history. And you will be observed and assessed by an examiner at the same time. The second type of OSCE station for breast lump will be an examination of a breast lump on a mannequin. This again, you will be observed by an examiner on the way you examine the mannequin in front of him. The other one station is the non-interactive, where you are shown slides, pictures or videos or specimens of items related to breast disease. And you are asked questions, short questions on the clinical features, diagnosis, investigations, and clinical aspects of the diseases are also posted for you to answer. The principles of treatment are also asked, and all you need is short answers, short and prompt answers to the questions posed. The first station, the interactive station, we'll have a look at in this station. You are given a patient presenting complaint of a patient with breast lump. You go through the information given and take a relevant history from the patient. Remember, the examiner will be observing and assessing your performance, including your attitude to the patient. So in this station, you are given Madam Tay is a 62-year-old retired teacher who presented to the surgical clinic with a mass in the upper outer quadrant of her left breast for a month. It is painless and increased in size during the period. Can you please take a detailed history from the patient? Okay. Hope you have taken a good history from the patient. Now we come to some instructions or go through some important points in taking history from a patient with a breast lump. First, the opening consultation and introduction, where you wash your hands, introduce yourself, confirm the patient's particulars, and explain to the patient that you would like to take a history from her. Gain the consent and proceed with the history taking. The next part is the presenting complaint. Use opening questions to explore the patient's presenting complaint. Subsequently, continue with the history of present complaint. And this is usually best to use the Socrates mnemonics to get the various details of the symptoms. Although these mnemonics were classically used for pain, but this can also be modified and used for breast lump. First, the site of the lump. Onset, get a clarity on the breast lump when the breast lump first developed. The character or the nature of the lump as how the patient feels it. If there is pain, radiation of the pain, associated symptoms such as ulceration, nipple discharge, and so on, or if it is an abscess, fever, the time course. Okay, ask the patient how this lump has changed over the time, especially in this patient for over the 1 month. exacerbating and relieving factors. Okay, what makes the lump worse and what makes it feel better, and severity, especially for pain. How severe is the pain? Having got all these particulars, next we'll be presenting, continue with the other parts. So this is a summary of the Socrates mnemonics representing the various aspects of the symptom. Okay, next we go into the systemic inquiry. In this systemic inquiry, don't forget the three most important issues in a patient with breast lump. One is the obstetrics and gynecological history and menstrual history, which include risk for the of factors for breast cancer. Then you look, second one is the hormone therapy, especially hormone replacement therapy and oral contraceptive pills. And the third one is importance is family history of breast cancer. Once you have got this, then you can come to the closing consultation. Okay, summarize the salient points back to the patient and ask if there is anything that has been missed. Okay, this chart here shows you the systemic summary of the systemic inquiry. Of particular importance will be gynae and obstetric history, hormone or drug history, and family history for breast cancer. Now, the second station which I was talking to you is the interactive station. And in this interactive station, second interactive station, the examination of the breast lump is assessed. And this is usually done on a mannequin. Again, you are told of the history. It's Madam Tay, a 62-year-old retired teacher, presents to the surgical clinic with a mass in the upper outer quadrant of her left breast for a month. It's painless and increase in size during the period. Conduct a proper physical examination of her breast and related and relevant systems. Now I shall show you a short video on the OSCE guide to breast examination.
Hi, I'm Simon, one of the junior doctors. Can I just check your name and age, please?
Yeah, it's Leola and I'm 23.
Nice to meet Leola. So today I need to perform a breast examination. Have you ever had one of these before?
No.
Okay. And which breast is of concern to you?
I felt a lump in my left breast.
Okay. So what this examination will involve is me having a look and a feel of the breast tissue. Are you happy for me to go ahead?
Yeah, that's fine.
All right. What I'll do is I'll let you get undressed, so taking your top things off, including your bra, and then popping this gown on to cover up. In the meantime, I'll fetch one of the nursing staff to act as a chaperone throughout.
Okay.
All right. Okay, Leola, if you could just put your hands on your hips for me, and now just press down on the hips. And now if you could put your hands behind your head and push your elbows back. And now just lean forward for me. Okay, thank you. Okay, Leola, if you could lie down for me now, I'm going to examine the breast. And if you could just put your right hand behind your head for me. Thank you. I just want to make sure that there's no discharge from the nipple. If you could just squeeze your right nipple between your thumb and index finger. Okay, thank you. If you could just switch the hand behind your head. Thank you. Now could you just tense your chest muscles, Leola? Thank you. What I need to do now is have a feel of the glands in your armpit, okay? So if I could start on the right, I'll just take all the weight of your arm, so just completely relax it, okay? Okay, Leola, I'll do the same on your left side now. So again, just relax, let me take all the weight. I'm just going to have a feel of the glands in your neck now, alright? That completes the examination. Thank you very much, Leola. I'll just leave you to get dressed now.
Thanks.
Today I performed a breast examination on Leola, a 23-year-old lady. On inspection of the right breast, there was evidence of nipple ulceration and there was erythema in the lower outer right quadrant. On inspection of the left breast, there was evidence of nipple retraction and also peau d'orange in the left lower outer quadrant. On palpation of the left breast, there was a firm, craggy 3 by 3 centimetre mass at approximately 2 o'clock. It was located 4 centimetres from the nipple and it appeared to be tethered to the underlying tissues. There were no other lumps on palpation and there was no lymph node involvement. For completion, I'd consider further examinations to detect the presence of disseminated malignancy. I'd arrange ultrasound scan and also core biopsy or fine needle aspiration of the mass.
Okay, this is the OSCE checklist for breast examination. First, introduction, inspection, masses, scars, symmetry, nipple discharge, and so on. Then you got your palpation, palpating the lump and other aspects of the breast. And the last one is conclusion, thanking the patient and preparing a short summary of the patient's findings. Okay, next we come to some practice OSCE slides on breast lump. OSCE number 1. This picture showing a left breast lump is of a 45-year-old woman. Describe what you see on inspection. What are the features that would suggest the lump to be benign in this patient? What are the investigations required for the patient to establish the diagnosis of the lump? Okay, answer is a discrete lump, periareolar region, about 3 times 2 centimeters with no skin changes here. The lump is here. Okay, well demarcated, no skin changes. What are the features that would suggest the lump is to be benign lesion? It is soft, smooth, well defined, with no skin changes and no axillary lymph nodes if on examination. What are the investigations for this patient? An ultrasound scan, mammogram, and FNAC. Okay. This table shows you the differences between benign and malignant lumps in the breast, which are very, very important. Okay. You must know this very carefully. The breast mass, malignant lesions tend to be single, hard, immobile, and irregular borders, whereas the benign ones may be multiple, rubbery in consistency, mobile, and well circumscribed border, as you see in this patient. Next, we look at the nipple discharge. In benign cases, they tend to be bilateral, multiductal, and milky in nature. Whereas in malignant cases, it is usually unilateral, uniductal, bloody, spontaneous, and persistent. Skin changes, usually benign, there are no skin changes, whereas in malignant lesions, there's retraction, dimpling, and thickening of the skin over the lump. OSCE number 2. This is the breast of a 45-year-old woman with a lump for 1 month. What does it show? What does the change signify? And how will you investigate this patient? So the answers to this question, this is what is called pure d'orange change of a breast. What does it signify? Underlying carcinomatosis of the breast. How will you investigate this patient? Again, the triple method, ultrasound, mammogram, and biopsy. Okay, this is a slide that shows you the changes that take place in pure d'orange. This is a normal skin with the sweat glands and their pores, okay, and the ducts. This is the subcutaneous tissue, and here pure d'orange where the dermal edema occurs as a result of superficial cutaneous lymphatic tumor, obstruction by tumor. So as a result, the skin thickness increases. Okay, epidermal thickness increases. The glands, ducts of the sweat glands act as a tethering agent for the increasing thickness of the skin, epidermis. This is due to the edema of the spreading, cutaneously spreading, infiltrating carcinoma. OSCE number 3. This patient is a 51-year-old woman who complained of a painless increasing swelling over her left breast for 2 months. Describe the findings. What is your clinical diagnosis? And describe the investigations for her. Answers. There's a large mass in the left breast below the nipple, which is smooth, resulting in deformed, puckered, and retracted nipple. Okay, you can see here, large lump here, smooth skin, no changes, but the nipple is puckered and retracted. What is your clinical diagnosis? Carcinoma left breast. The investigations for her will be ultrasound, FNAC, or core biopsy, and if it comes as positive, we continue with further investigations like this CT scan for the staging of the disease. Okay, this is another view of the breast cancer with associated puckering and nipple retraction. And this is due to the contraction of the Cooper's ligament as a result of infiltration by the tumor. Then OSCE number 4. This is a 27-year-old woman breastfeeding for the last 3 months, presents with a painful swelling of her left breast and fever for 2 weeks. What is the most likely diagnosis of this patient? What is the most likely cause? And what is the treatment for her? Okay, you can see the breast is enlarged and diffuse with extensive redness and inflammation. And maybe there is a localized swelling here suggestive of an abscess formation. The most likely diagnosis is galactosile leading to mastitis and possibly an abscess of the breast. What is the most likely cause? Mammary duct blockage leading to breast congestion and galactosile during lactation. What is the treatment for her? Hot compression, massage and manual expression of the milk using a pump, antibiotics, and incision and drainage if there is evidence of abscess forming. Breastfeeding should be stopped and the patient should be counseled on the methods of breastfeeding. Okay, this is a picture, diffuse mastitis with probably an abscess forming here. Another one here, diffuse mastitis with the abscess here. Here again, diffuse mastitis with the abscess beginning to form here. And this is after doing an IND or incision of drainage of the abscess. OSCE number 5. This picture is of a 57-year-old woman. What would be the most likely complaint of this patient? What is the possible cause? And how will you investigate her? Okay, this picture here shows you a nipple with multi-duct discharge of blood, bloody discharge from the nipple. And maybe there is a lump beneath the nipple in the areola here. The most likely complaint of the patient will be blood discharge from the nipple, which is multifocal in nature, and maybe a subareolar lump as well. Yeah. What are the possible causes? Ductal papilloma, duct ectasia, nipple infection, and intraductal carcinoma. How will you investigate her? Send the discharge for a cytological examination, do a culture and sensitivity, followed by an ultrasound, mammogram, and biopsy. It is significant. This multi-duct discharge is most commonly caused by duct ectasia with secondary infection. In cases of ductal papilloma and ductal cancer, it tend to be focal or duct discharges. Okay, only one. There will be one duct that is discharging in malignancy or ductal papilloma. Now, this is how the causes of nipple discharge in patients. All depends on the type of discharge. Okay, if it's clear, it's mammary duct ectasia. If it's bloody discharge, think of intraductal papilloma or intraductal carcinoma. If it is brown in color or rusty discharge, fibrocystic disease, or mammary duct ectasia. If the discharge is greenish in color, then you think of fibrocystic disease. Yellow discharge is usually pus, and it is due to underlying infection, mastitis or breast abscess. If the discharge is milky, then the patient is lactating, she is breastfeeding, or she may have hormone-related causes that leads to galactorrhea. Okay, here the four types of discharges and the possible causes of them. Okay, so the most important, and there is as far as seriousness is concerned, blood stain is the most important. Ductal papilloma is the most common cause, but you must always keep in the back of your mind intraductal invasive carcinoma, although it is not so common. Medications can also cause nipple discharge. There are a long list of medications, of which the most important will be estrogens or oral contraceptives, which are the most commonly taken. OSCE number 6. This is a picture of the breast of a 60-year-old nulliparous woman. What is the sign exhibited? What does it signify? What's the best way to demonstrate the sign? Okay, this is a breast. There's dimpling of the breast here. Okay, puckering and dimpling of the skin. And what does it signify? Malignant, underlying malignant lesion. Best way to demonstrate the sign is to elevate the arms above your head, and that will make the dimpling less prominent, more prominent, and the prominence decreases as the patient lowers the arm back. It must be taken in stress that in a 60-year-old or an elderly woman, breast lump with puckering is a definite sign of underlying carcinoma. It should not be missed. Okay, OSCE number 7. This is a 28-year-old woman with a lump in the upper lower quadrant of her left breast. What is this investigation being done? What are its indications? And below there is a image taken during this investigation. What does it show? The investigation done is ultrasound scan of the breast. This is the probe, ultrasound probe on the breast. What are its indications? Lump in the breast, pain or mastalgia, swelling, abnormal mammogram findings are definite indications for an ultrasound. What is the image of this? The image. What does this image show? It's an hypoechogenic, solid, well encapsulated lesion in the breast. Most probably a fibroadenoma. Okay. Now the investigations of breast, a number of them. The first one is ultrasound, followed by mammography, and the third one is fine needle aspiration. These are the three important investigations that must be done in all patients with breast complaint. Less commonly done is MRI, which is usually done in very dense breast or ruptured breast implants. Core biopsy to differentiate invasive or in situ cancer. Nowadays, large core vacuum assisted core biopsy can be done. And lastly, open surgical biopsy or excision biopsy may at times be needed in some patients. Here again, mammography, I must impress on you that not done in women under 35 unless there's a strong suspicion of cancer. Okay, this will be explained to you a bit later in this session. What is this investigation? Why is it done? And how is the results classified? This investigation is called mammography. It is done as a screening for breast cancer and to confirm and evaluate a breast lesion complained by the patient or detected on ultrasound. The results are classified as in this table. The breast imaging reporting and data system are BIRADS, which can be classified as BIRAD 0 to 6. 0 where it is normal and nothing, not defined. BIRADS 1 is negative. BIRADS 2 is benign lesion. BIRADS 3 is probably benign. Okay, there is some suspicion of malignancy. 4 is suspicious abnormality. BIRADS 5 is highly suggestive of malignancy, and BIRADS 6 is a biopsy proven cancer. Okay, now some notes on cancer on a mammogram in a fatty breast versus a dense breast. Okay, this is a fatty breast and this is a dense breast. Dense breast occurs in young women where there's more glandular tissue compared to older patients where there is more fat infiltration into the breast. The higher the content of fat makes it small lesions detectable on mammogram. Okay, here you can see a small cancer which is easily seen in a fatty breast. In a dense breast, even a large cancer here is difficult to detect, difficult to differentiate it from a normal breast tissue. Okay, these again a series of mammograms. A here is fatty breast, okay, and the last one D is extremely dense breast. Here mammogram is virtually not useful for the detection of breast cancer, whereas here it is very useful. It can be seen here. Okay, scattered and heterogeneous breast. All right, so this is a series of changes to show the BIRADS changes. Benign breast tumor mammography, normal mammogram, you can see here. Benign cyst, not cancer, and a very dense lesion which is malignant. Okay, breast cancer. Here another lesion here, breast cancer, speculated calcifications and very dense. This is another feature of a breast cancer. Okay, this is the BIRADS breast imaging reporting and data system. Breast composition categories level 1, BIRADS 1, 2 and 3 are all benign and they look like this. This is extremely dense, suspicious of malignancy, so these lesions must be biopsied. Okay, these are the various grades that corresponds to the report as shown here. Okay, level 4 is suspicious abnormality which must be biopsied. Level 3 here probably benign. So these patients, if risk factors are high, can be biopsied. Otherwise, they can be followed up with regular ultrasound and mammography. These two, Mirage 1 and 2, can be observed with follow-up ultrasounds and mammography. Now we come to OSCE number 9. This procedure is done on a 62-year-old woman who presents with a lump in the upper outer quadrant of her right breast. What is the procedure? What are the indications of the procedure? What are the complications of the procedure? Okay, you look at this picture. This is an ultrasound probe and this is a syringe with the needle. So this is a ultrasound guided FNAC. Okay, probe, nodule and a needle. Ultrasound guided FNAC. Indications: to confirm the presence of or absence of malignancy. What are the complications? Bleeding, hematoma, dissemination of the tumor and infection. In fact, with fine needle aspiration, these complications very much less compared to needle biopsies or core biopsies. Okay, and this is a slide showing you the cytology report and the core biopsy report. Okay, and here they are in the cytology report, C1 to C5. C5 is malignant, C1 is unsatisfactory, C2 is benign. And in between 3 and 4, suspicious of possibility of malignancy is there. Again, core biopsy, B1 to B5. B5 is malignant, B1 is unsatisfactory, and B2 is benign. 3 and 4 are in between with a small possibility of being malignant. OSCE number 10. What is this procedure being done in a patient with a breast lump in a right breast? Why is the procedure done and the limitations of the procedure? Okay, this is the breast, the lump here. The dye is injected into the peritumor tissues, and it is traced until it reaches the nearest lymph node. The lymph node is detected, excised, and sent for histology to confirm the presence of malignancy. If the tumor is negative, it can be inferred thereby the other axillary lymph nodes will be negative. So this will decide not to carry on with axillary lymph node clearance. Just do the local breast treatment. These days, this needle, instead of injecting around the tumor, is injected subareolar, and then it is traced up to the first group of lymph nodes where the dye is detected. Okay, here. Now this is also radioactive isotopes are injected together with this dye, which can then taken up by the lymph nodes, and a scan of the radioisotope scan will be done to detect the lymph nodes that uptake those radioisotopes. And these lymph nodes are taken and sent for biopsy. This is because of this radioisotope addition, it is much more accurate and the results are more positive. Okay, and this is known as the sentinel lymph node biopsy or sentinel lymph node mapping. Why is the procedure done? To map out and identify the sentinel lymph nodes so that to avoid an unnecessary axillary clearance with its complications. The limitations is the procedure false positive or false negative, especially false negative. Okay. This is how it is done. The tumor dye is injected. The second stage, it is the lymph nodes are detected, and with a probe, radioisotope probe, and these lymph nodes are excised for biopsy. And if it comes back as negative, then axillary clearance is not done. If it is positive, then axillary clearance will be done. Okay, so it follows 3 steps. The first one is known as first panel, where this injection is done. Second panel or middle panel is where the lymph nodes are biopsied, and the last panel is where the lymph nodes are sent for histology and the results detected. Of them, central, lateral, and posterior. Okay, this is the axillary vein. So the lateral, this is the posterior, which is related to the scapula. Then you have the central group in the center of the axilla. You got the anterior axillary nodes, which is related to the below the pec major, pectoralis major and minor. And then the apical is related to the subclavian or axillary vein. Okay, as it goes to join the, as it goes to form the subclavian vein here. These are divided by into 3 groups, 1, 2, and 3, and basically by the pectoralis minor. Okay, a short note about this triple assessment for diagnostic tests. All breast lumps or suspected carcinoma must be subjected to a triple assessment, which consists of history and clinical examination, radiological assessments like ultrasound and mammogram, and cytological assessment as FNAC. Okay, so this is the clinical examination. This is the ultrasound scan. This is the mammogram, and this is the fine needle aspiration. Depending on whether this is positive for malignancy, if it is positive, then further staging investigations should be undertaken, such as liver ultrasound, staging CT scan, chest x-rays, and wound scan. Okay, thank you for joining me in this short session on OSCE on breast lump. Thank you.